Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Is it cancer? One of the most difficult problems that the practitioner faces is to decide whether a given lesion constitutes a threat to the patient's life or not. And this is the question that we'll focus our attention on today. Recognition, of course, is oral diagnosis. This requires an astute, alert examiner. Identification of the process, however, requires the use of certain tests. We'll talk about one of the questions today, in other words, is it cancer? And we'll talk about an appropriate test methodology, that is the microscope, and show how these two dovetail together to form as good an answer as can be had on this particular problem. When typical, with its rolled edges and depressed center, visualization is almost enough. Occasionally, however, tactile sense adds greatly to the dimension for diagnosis. In this situation, however, these two senses alone are not enough to resolve the problem. Here we must go to the microscope. This typical lesion on the cheek is hyperkeratosis. What do we mean when we say hyperkeratosis? Essentially, we're talking thickening of the oral mucosa. Diagrammatically, we might represent it like this. This being the basement membrane area down here, this being the surface up here. Now, in hyperkeratosis, the surface might or might not be elevated, but the thickness of the keratin layer is increased. Now, on the other hand, we can maintain the thickness of the epithelium, making it thicker, but having the keratin occupy a relatively thin layer as it does normally, and have the great majority of the increase be in this area rather than in this area. This would be called acanthosis, whereas this would be called hyperkeratosis. Both of these conditions serve to mask the underlying pinkness of the buccal mucosa, and this is what produces the white appearance to the lesion. Let's go to the microscope and see what these look like. This is a biopsy specimen of a 43-year-old female who shows a white lesion on the inside of the cheek, much like the one you just saw clinically. Now, the important thing here is orientation. The surface is on the right side, and the basement membrane of the epithelium is the dark line. That's right where the pointer is there. Now, we'll move this specimen from the into the field of view, from bottom to top here. And notice the way the epithelium gradually gets thicker. And as we move up into this area, you can begin to see the epithelium now is at least twice as thick as it was earlier. Now, on the surface, you can see hyperkeratosis, that's right, in the form of what would be clinically, if it were on the lip, a scale or flake, and this would be a flaky lesion. However, on the cheek, this just shows a separation. This is an artifact that it has separated from the underlying tissues. The important point here is to see that the epithelium has thickened, and that the thickening is the result of primarily acanthosis, which is lying between the basement membrane and that area of hyperkeratosis, and additionally it has a very thin film of hyperkeratosis on the top. As we move on down, we can see that the lesion gets thicker and thicker, and then begins to subside again. So this is a relatively small lesion. Let's go to a higher power and examine the cells. Looking at the surface layer here, which runs right down the middle of the screen, we see that the surface cells have not lost their nuclei, and therefore, instead of calling this hyperkeratosis, we should probably call this hyperperatosis. Now let's move down deeper into the epithelium and examine the cells. You can see here that the cells are swollen, and that's what gives the empty spaces around them. The nuclei have shrunk, and fluid has been incorporated within the cytoplasm of the cell. As we move down closer to the basement membrane junction, we can see that the spinous cells undergo a very orderly maturation process down to the relatively small cuboidal-looking basal cells. Notice that the collagenous tissue deep to the epithelium, which we call the subepithelial connective tissue, is relatively acellular, lots of pink there, and very few little blue polka dots. Now, the blue polka dots are, in fact, inflammatory cells, lymphocytes for the most part. All right, so we have then only the only atypicality here is an increase in the thickness of the epithelium and the retention of keratin on the surface. So we call this combined acanthosis and hyperperatosis. A quick look at the deepest of the cell layers within the epithelium just to convince you that these cells are very normal appearing. Let's trace the basement membrane area so that we see we're looking, that's right along there. And the cells right next to the basement membrane area are the cuboidal appearing basal cells, whereas those within the central part of the epithelium that you're looking at here, the center part of a reedy ridge, these cells are larger, they have more cytoplasm, and this is the stratum spinosum. Now we'll look at these cells under more careful scrutiny in the next condition. We may have led you to believe that hyperkeratosis or acanthosis can occur alone, and that's correct. But oftentimes we see them in combination, as you saw to some extent on the last slide. Primarily acanthosis was the problem there. Let's diagram what we'd expect to see when these two conditions are combined. Let's start with the basement membrane junction, because I feel this is the most important area for examination. The basement membrane junction does not change despite the tallness or the thickness of the epithelium. So the epithelial surface then increases in height, and a good bit of that increase in height is due to an increased thickness of the keratin layer, whereas another abundant portion of it is contributed by the squamous cells in what we call stratum spinosum. So this then is acanthosis, and this then is the hyperkeratosis. Let's look at a patient and see what one of these lesions typically would appear like. This is a lesion of the lower lip, which has been everted so that you can see the inside surface a little better. Here you can see the white lesion. Let's go to the microscope then and examine this. A biopsy specimen from this patient, who is a 52-year-old male who presented this white round lesion in the lower lip, reveals at the right-hand edge of the screen a normal thickness to the lip mucosa, whereas as one moves to the left, it is apparent that a little farther, the epithelium thickens up quite tremendously. Now we'll see with the next power that this thickening is due to hyperkeratosis combined with acanthosis. And the important thing to note here is that the basement membrane crowds against the underlying connective tissue, but that the lesion itself is an exophytic one, that is, one that projects into the mouth rather than invading the underlying tissues. At this intermediate power, it's very clear that the lesion is both hyperkeratosis and acanthosis. That up toward the right-hand side, all above the pointer from the right over, is hyperkeratosis, and that from the tip of the point to the left, which is the basement membrane area of one of the reedy ridges, is acanthosis. So now you see the junction, hyperkeratosis above, acanthosis beneath. Let's now go to the highest power and look at the individual cells. The highest power reveals clearly that the basement membrane junction is very obvious, comprising perhaps the lower 1/3 of the screen is the connective tissue, and the top 2/3 of the screen are the epithelial cells. You can see here how the epithelial cells at the junction between connective tissue and epithelium tend to be cuboidal in shape. The nuclei are all about the same staining intensity, and as you move upward, the cells become larger, and the space between them becomes more conspicuous. In the microscope, we can distinguish in the upper part of the screen the spinous processes, which look like the little burrs that catch on your trousers that hold the cells clinging together one to another. Now we'll introduce, in the next case, two very important features which will bring a little bit of question to the diagnosis of innocence to these lesions. These two features are invasion and diskeratosis. So let's draw again the epithelium. We'll draw the surface. We'll draw the basement membrane area. Invasion takes place at the basement membrane area. Here, instead of seeing the nice even junction that we've had in the past, we'll draw it with the red crayon and show now what changes to expect. This kind of an activity, you see, which pushes the epithelium into the underlying tissues, with growth being in a downward direction, whereas the surface remains relatively flat. Up to this time, we have noticed that all the hyperplasia of cell activity has bulged the surface upward, but not penetrated into the underlying tissues. So here, for the first time, we see invasion. And we'll begin to see some features in these cells which will be identified later as features of malignant cells. And this is the area where you look to find them, in the basilar and the parabasilar areas of the epithelium. Let's see what this case looks like clinically. Here you can see a carpenter who is aged 65, who has been out in the sunshine. His lips evidence actinic change, the indistinct edge you see where the vermilion joins the skin surface. But additionally, you see tiny little crusts on the skin. This is actually a scale, which is, in fact, we'll discover microscopically, hyperkeratosis. But the important changes occur beneath it. But I want you to notice that there is no bulged upward lesion, just a slight little scale that's very innocuous on the lip. Let's go to the microscope. You'll notice at the lower left, where the surface is, you can see the scale, which is hyperkeratosis, thin and flat, lying upon the attenuated or thinned underlying epithelium. Immediately below the epithelium, a few lymphocytes are present. Now let's move into the center part of this lesion. Now we discover something new has taken place. The epithelium has thickened up, but at the expense of the underlying connective tissue, and slender, elongated, finger-like projections are penetrating into the underlying connective tissue. Let's go to a higher power and examine them. The intermediate power reveals even more clearly the downward penetration of the reedy ridges into the underlying connective tissue. And here I'd like to call your attention to a rather conspicuous and perhaps in the future we'll discover important feature, and that is the presence of all these lymphocytes, all the little black dots there around the epithelium. These lymphocytes are immunocompetent cells which may be reacting immunologically against the process that causes the epithelial downgrowth. Let's look at the cells under a higher power. The invasion was apparent with the low power. High power is used to see the dyskeratotic process. Now on the left, or rather on the right-hand side of the screen, occupying most of the screen surface, are epithelial cells. Let's trace the basement membrane with the pointer. Now you can see that we have lost those cuboidal cells which very neatly outlined that junctional area in the earlier slides. Here the cells are spindle-shaped, and in the center of this reedy peg, or reedy ridge, the cells have the same spindle-shaped as they do down at the basement membrane junction. This is one of the features of cell change in shape, which we call pleomorphism, meaning many-shaped cells. So we're looking at pleomorphic cells in the basement membrane area going up into the spinous cell layer. The diagnosis on the last case that we have shown you would be called focal atypia. This is a different case, but I've put it on to illustrate dramatically some of the changes that the epithelial cells undergo in the dysplastic process. Let's go over to the extreme right edge of the screen at one of the keratin pearls. That's right there. You'll notice that the cells undergo the normal maturation sequence tending to make keratin, but they've lost their surface orientation. So the keratin piles up in places where ordinarily you'd not find keratin, namely deep within this lesion. So here then is a well-defined keratin pearl. Let's look next to it at the next keratin pearl. You see a few nuclei are retained. It's almost like parakeratin. And if we go up toward the edge of the screen, we can find individual cells that are themselves keratinizing. And this is one of the features of dyskeratosis, as it's called. Diskeratosis refers to the manufacture of the mature product keratin, but in peculiar places. Let's go down to the center here, and you can see some more attempts at individual cell keratinization, two of them adjacent to one another. The nuclei are pycnotic and the keratin is piled up. Additionally, you'll notice that some of the nuclei straight above that individual cell are very dark and dense. This is called hyperchromatism. So we have hyperchromatic cells, we have diskeratosis, we have lack of surface orientation and invasion, all displayed in this lesion, which just came across the board this afternoon in a frank malignant squamous cell carcinoma. Let's go to the clinic and look at the next case. This patient also presents a rather innocuous appearing lesion of the tongue. It lacks the surface papillae and some of the highlights, but is otherwise unremarkable. At the extreme right of the screen is the surface, and at the left, correspondingly, you can see the basement membrane junction of the epithelium. Now, at this power, about all we can say is that there is no longer an orderly maturation sequence of the epithelium. As a matter of fact, the disturbances run from top to bottom. So you see they are a little more advanced than the last case, but are the same type of changes. Let's go to a higher power and examine them. One of the most conspicuous features at this high power is the presence of mitotic figures. For example, there is one dead center in this section, and there is a second one off to the right. Now, we'll move around and look for more mitotic figures, but in the meantime, I'd like to call your attention to a few other atypical features. Between those two mitotic figures, there are two cell nuclei. One is almost twice the size of the other, and the larger of the two has two nucleoli within it. Now we'll move around and look at other cell atypicalities. For example, in this field, there is a mitotic figure close to the basement membrane at the left side center. There is another one at about the same level off to the right, almost at the right edge of the screen, also nearly at the center. There is another one, a third one in this field, up at the extreme top border of the screen. We'll move it down a little, if we can here. And in this field, we see that we have two mitotic figures, or three mitotic figures again, in focus. One is just to the left of the center of the field, one is just to the right of the center of the field, and one is up at the top left of the field. You can see now that these mitotic figures are no longer the classic figures. For example, there is a fourth one I see now, or the fifth one even, at the bottom edge. The classic one is at the bottom edge to the left, and you can see the two bars of the chromatin material nicely lined up, whereas in all of the other mitotic figures in this field, the chromatin distribution appears irregular. Now, this is one of the features of atypical hyperplasia, that is, cells growing rapidly and a little bit bizarre. A little bit bizarre in their staining characteristics, a little bit bizarre in their nuclear size, a little bit scanty, as a matter of fact, in cytoplasm. So we could say you have an increased nucleus to cytoplasmic ratio and an abundance of mitotic figures, several of which appear a bit bizarre. Let's move around and just look at this slide a bit further. You can see that the dermal, or rather the connective tissue papillae project nearly to the surface, and you can see the pink appearing red blood cells in them, a few inflammatory cells. Moving further to the surface, look at the size of the nuclei. Remember earlier, this was where we found parakeratin and ortho-hyperkeratosis. That is, keratin devoid of all nuclei, and yet look at the large nuclei here to be shed to the oral cavity. It is on lesions such as this that exfoliative cytology is successful with these large, heavy staining nuclei. These are obviously atypical when viewed. Look at that one that now is being brought to the center of the screen. That one would appear quite bizarre on exfoliative cytology, and the one just above it and to the left is almost binucleated. So here's a binucleated epithelial cell. These are worrisome features, and this patient that you're looking at now and the one just preceding it would be classified as atypical hyperplasia. and they would constitute the problem category. Is this cancer or is this not? Well, most of the features would suggest that they were benign. But on the other hand, some of these changes are the changes of cancer. Therefore, we view these lesions with considerable alarm. Benign, malignant, and now a gray zone in between. Why not just call it cancer and be done with it? Well, the therapeutic procedures required for cancer as opposed to non-cancer are quite different. Perhaps we can illustrate that with the next slide. This patient presents a mass on the palate which bears a biopsy scar. This lesion is benign. Let's see how it is treated. Simple excision effects complete cure, and here you see that patient with the benign lesion removed. Suppose that lesion had been malignant, how would it be treated? Here you see a patient who had a very small lesion of the palate, about the same size as the previous lesion, but it was malignant. This requires that adjacent normal tissues, such as to encompass all possible malignant cells, have to be removed. This then creates a defect, and you can see into the nasal cavity here. This patient can neither swallow nor speak after the loss of this tissue. So you see, the diagnosis of cancer carries with it considerable responsibility. We, at all lengths, wish to avoid treating non-cancers as cancers. This is a 58-year-old man who presents a small ulcer on the floor of the mouth. This lesion has been present for 6 months. Low-power examination of the biopsy specimen reveals epithelial proliferations at one edge, central ulceration, and then epithelium again at the far edge. Deep to the surface, salivary gland is noted within the connective tissue. This is the area over here that we'll examine with higher power. The surface is at the lower part of the screen, and it is apparent that the epithelial proliferations are migrating deep into the subepithelial connective tissue. We'll move this slide just a bit. And note that the character of the epithelial cells changes just a bit as they move deeper into the tissue. The cells become larger, and in some instances, more deeply staining nuclei are apparent. Inflammatory cells are present within the connective tissue surrounding the epithelial proliferations. High power reveals the individual cell characteristics which connote neoplasia, malignant neoplasia. Small cells in juxtaposition to large cells, deeply staining nuclei, which is hyperchromatism, adjacent to nuclei which stain much fainter. We see mitotic figures in this area, and invasion is apparent. The basement membrane has been lost, and the individual epithelial cells are migrating into the deeper tissues. A contrast of these features is apparent when one looks at the normal epithelium over at this edge as opposed to the neoplastic epithelium at this edge. Basement membrane is clearly discernible in this area, which separates the epithelium from the subepithelial connective tissues. Whereas in this area, the epithelial cells have lost their basement membrane. It's hard to say just where it should be in here. The epithelial cells in the normal appearing area exhibit the normal maturation sequence, basal cells up to the spinous layer and on up toward the surface. Whereas over here, basal cells are absent or mixed up with the other cells. For example, this is probably a basal cell here, and the larger spinous appearing cells are in the reverse direction toward the deep aspect of the section. This is a 54-year-old male who presents a non-healing ulcer of the lip. This has been present for about 3.5 months, he says. Low-power examination of the excised specimen reveals normal epithelium at the edge. Now we'll move toward the area of the cancer. As we do so, you can see that a keratinaceous scale is present on the surface, and the epithelium begins to penetrate down into the connective tissue beneath. and large proliferations in this area. Let's move over toward the edge of the specimen here. Now, so far we have seen penetration. High power reveals the basement membrane indistinct in this area, but the cells themselves not terribly impressive, perhaps a bit large, perhaps a bit hyperchromatic, but not striking in malignant features. And this brings up an important point. The biopsy specimen must be obtained such that the most malignant part of the lesion will be displayed. Let's go to the chalkboard and illustrate this. The dentist, in removing the lesion, excised the lesion in its entirety. The biopsy was designed like this. To include all margins of the suspect growth. The excision extended in the deep aspect to encompass beneath the lesion. Now, when that lesion is brought to the pathology laboratory, let's see how it is handled. This is the way the biopsy specimen is received in our laboratory. It measures perhaps 2 centimeters or 1.5 centimeters in width this way, or length, and it probably measures about 1 centimeter in width. Now, the question that the practitioner wants to know is, first of all, is it malignant or benign? But if it is malignant, which is the case here, he will want to know, have I removed the entire lesion? And in order to answer that question, we must treat the specimen in a particular way. For example, we will divide it lengthwise. Taking a thin sliver all the way from top to bottom out of its center. Then we will be left, you see, with 2 halves. These we will divide in this plane, so that we will have this one will give us a representation like this. And these will give us representations like this. Now, the one that you just saw with the microscope represents this segment here. And you can see you had normal tissue at the edge, malignant tissue at the center. Now we'll return to the microscope and look at the center cut and see if the margins here are clear as the first one was here. The cancer is apparent in the central portion. The surface up here is followed by these down growths, each of which is forming keratin in its central portion. We call these keratin pearls because they are whorl-like aggregates of keratin within the deep tissues. The border of the squamous cell carcinoma is down here with muscle beneath. Let's examine in low power this specimen then from edge to edge. One edge reveals relatively normal epithelium at the edge. We'll follow it into the central portion, and we discover more and more atypicalities appearing until we're in frankly cancerous tissue. Then we move past the center and see the atypicalities diminish until at this edge relatively normal appearing epithelium also is present. Examining the deep aspect, we see muscle bundles present. At the extreme left of the screen, we can begin to see the cancerous changes, but there is a border of normal tissue all around these changes. So in certainly the center portion of the specimen, the malignant tissue has been incorporated or enclosed within the excised specimen. Let's go to a slightly higher power and examine the atypicalities in this specimen further. Mild hyperchromatism in this area, pleomorphism in the form of large and next to it small cells, individual cell keratinization, which in this area takes the form of a keratin pearl, mitotic activity, probably here and here, maybe over at the edge of the screen over here. But basically, we are looking at tissue abnormalities in addition to the cellular abnormalities. That is invasion and loss of surface orientation. We call the loss of orientation relative to the surface loss of polarity. That is, this material ought to be at the cell surface instead of deep within the heart of this lesion. Let's now go to the opposite edge of this specimen. The edge of this specimen reveals normal stratified squamous epithelium along the surface, some hair follicles, and sebaceous glands, indicating that this then is the skin edge of the lesion. We'll move into the center portion, all normal, and at this edge we begin to see atypicalities appear. Here we see the proliferating epithelium. Here we can see some pearls. Following it further, we find the keratinaceous crust on the surface. And this then is the artificial line of excision where the central portion, which you saw on the last slide, came from. Let's go to a higher power to look at one feature here, and that is invasion. Surface is at the bottom of the screen, considerably removed. These are epithelial proliferations extending down toward the muscle beneath. Here is a muscle fiber here, which is degenerate, and as we move the section, we can see the epithelial proliferations wedging in between muscle bundles and causing atrophy and replacement of those bundles by neoplastic cell proliferations. This is invasion. Our earlier proliferation of epithelium into the subepithelial connective tissue might be called proliferation instead of invasion, because actually it hadn't gone perhaps deep enough. It was hinting toward invasion. But this is frank invasion because epithelium does not belong in muscle. So seeing it here tells you that this is an invasive squamous cell carcinoma. This is a 72-year-old male who presents a small bulging lesion superior to the tonsil. Low power reveals an intact stratified squamous epithelium over numerous aggregates of epithelial cells beneath the surface. Now at this power you can't tell if they're epithelial cells or whether they might be lymphocytes, as a matter of fact, because they are so dark and blue. It is apparent, however, that nuclear material is present in overwhelming quantities and cytoplasm is scarce. Let's go to a higher power and check this out. Higher power reveals the epithelial cells aggregated by collagenous septi into groups. Now, also present in here are the small little dark blue dots, which are in fact lymphocytes. And this is one of the features of squamous cell carcinomas in this region. That is, lymphocytes and epithelial cells intermixed. And the epithelial cells themselves, as we'll see on higher power, resemble to some extent lymphocytes also. High power reveals the cells to have large, extremely hyperchromatic, pleomorphic nuclei with virtually no cytoplasm. When this is the case, you see they resemble lymphocytes. Another area reveals additional disturbing features in this particular lesion. The cells which were so neatly bounded into aggregates by collagenous tissue now are seen to trail off into the stroma in groups of 1s and 2s. This is what is called lack of cohesion between the neoplastic cells, and this is an ominous finding because cells that no longer stick to the main tumor mass are liable to be carried away by the bloodstream, and this then is the source for metastatic lesions in distant organs, such as lungs, liver, bones, brain, lymph nodes. We've examined a number of lesions, beginning with the most benign and ending with a very dangerous, highly malignant squamous cell carcinoma. We've tried to point out that the cellular features are not visible to the naked eye, and that's why biopsy and microscopic examination is imperative with these lesions to determine their true nature. We have shown also that cell characteristics and tissue features in concert make the diagnosis, that any one feature alone may raise suspicion or cause alarm, but it in itself is not sufficient to diagnose cancer. Rather, the diagnosis of cancer in these lesions is in concert a number of cellular and tissue abnormalities. In review, these features are cellular features would include hyperchromatism, pleomorphism, individual cell keratinization, and mitotic activity, which is abnormal both qualitatively and quantitatively. The tissue features would include invasion and the loss of polarity, which sometimes is called dyskeratosis. These cases that you examined today are typical examples of the material that crosses our examination desk in oral pathology. All of these cases were received within a 1-week period. And you can see how each one is resembling or related to one another, and yet we do not yet know that cancer is a direct transformation from any one of these cases to the next. For example, hyperkeratosis does not necessarily bring with it next acanthosis, nor do those two bring along with it loss of polarity and invasion. Cancer is one of the most difficult problems that the clinician and the oral pathologist have to deal with, but this problem can only be resolved successfully when both work together.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.